Good morning, sir. I invite Professor JOGI V. PATTISAPU. He is a pediatric neurosurgeon, presently professor at Bennett School of Biomedical Sciences, University Central Florida College of Medicine. He was a founding emeritus medical director for pediatric neuroscience, Arnold Palmer Hospital for Children, founding medical director for pediatric neurosurgery at Florida Children's Hospital. He had his basic education in science at Houston Baptist University, MD in University of Texas, uh, intern at General Surgery, University of Mississippi, resident in neurosurgery at University of Mississippi, and fellow in pediatric neurosurgery in the University of Utah School of Medicine. And he was a American Board of Neurosurgeons certified and American Board of Pediatric Neurosurgeons certified him twice in 97 and 2006. He has several presentations in national and international journals and been in private practice from 1990 to 2010. His professional associations has an exhaustive list. He was president and chairman for several associations. And industry experience, he developed the Medtronic PS medical shunt between 82 and 92, 88 and 92. He was an expert panel for intrathecal baclofen pump, consultant for Integra Research and Development. And with this few lines, I request Professor JOGI V. PATTISAPU to start his lecture.
Namaskaram, Andy, and good morning. I think we're starting about 25 minutes late. We have a president's oration.
Very sorry.
No, you have to maintain for the president's oration. That's important. Namaskaram, Andy. I'll do my best. I'll cover the first part and hopefully share some things about hydrocephalus, which not as exciting as some of the other things as tumors and vascular, but unfortunately very common, especially in the developing world and in the pediatrics. The main issue is that we can still learn from our predecessors because we don't understand everything. In this group, as well as in combined experience, we'll give a lot. Some simple examples. We'll just cover about 4 or 5, 6 topics to make it happen. Friends, I'm very proud to see the Indian contribution to global neurosurgery in the past decade, 2 decades. You have now come on the world stage, as we just heard Professor Sanjay excellently showed. He matches everything else you see from Phoenix to everywhere else. So very nice to see. The topics we need to talk about are some pediatric hydrocephalus, some adult issues in NPH, which is now increasing around the world, the use of programmable antibiotic shunts, etc., and some endoscopy, which has a role to play. A few scientific concepts. The main problem we have is that most of our science in hydrocephalus is clinical and device-oriented. I believe it's something wrong compared to other fields. We need more basic science, so I'll touch upon that if time allows. And we have multiple manifestations of this condition, which we need to somehow make it better. If we can come out with a combined theory of hydrocephalus and CSF homeostasis, friends, I think we'll do a better job, and I hope to do some stimulation to rethink our understanding. Unfortunately, we have a lot of theories, some suspicions, but we really don't understand it because our knowledge is very, very limited. But we should have the confidence, like Zig Ziglar said, if you're going after Moby Dick, take along the tartar sauce because you will win. We hope to win. Here's a simple understanding of the many causes of brain fluid accumulation, otherwise known as hydrocephalus. But it's anywhere from trauma, which is increasing. More patients are surviving that. More patients are surviving intraventricular hemorrhage as babies and infections. And we have now survival rates higher. Therefore, the incidence is higher. There are lots of theories about environmental causes, especially in NPH and the increase in tau protein and the problems with our adult problems with NPH. And still a huge unknown. We're not sure we know what causes it. It can cause it through some problem in the cell or directly block the CSF absorption. And the problem we have is that we have infinite shunt operations thinking that's the only cure. So we have a problem. Interesting that most of the data are from the West. However, the problem is heavily outside the US and the West. India, as our good friend Venkatraman has written from Bangalore, yes, you have a good number. And I have operated in India, Uganda, Ukraine, other places. And we have a tremendous understanding. And friends, the number one shunt used in the world today is still the Chabra shunt. So India's contribution is huge. And the experience, and if friends like you and others will find a better way, hopefully you'll be able to teach us to rethink how we approach this. And as I said, the only treatment is shunts, shunts, and more shunts, and occasional endoscopic third ventriculostomy. But the graph on the top shows that there's a continual failure, especially in the young babies, but even in the adults. 50% of shunts will fail within 4 to 10 years. Within 2 years, we have a significant number of them fail. And if we think about it, we would not be happy if we took our car to the mechanic and we have so many recurrent problems. We'd be so unhappy with the car mechanic, but yet our patients still trust us. Some of them are they're avoidable complications and misjudgment, but a lot of them could be to improve infections, which I'd like to talk about. And is unfortunately, a shunt is like a diamond, it's forever. And it's very, very difficult, but we should do our best to keep these complex patients out of the hospital and out of the OT as best as we can, if we can find better ways. At this time, this is my secretary's hand with the pile of shunts that we have that we can say plenty of. And I like this quote from Professor Ashoff: man, we should not use bad valves or misguided valves. And I always used to use this joke for my residents and students. Hydrocephalus, the definition means hydro means shunt and cephalus means malfunction. So it's the life of neurosurgery with hydrocephalus. Programmable shunts have made a good progress for us, extremely expensive, unfortunately. But in my humble opinion, only about 15% or so of patients absolutely need a shunt that can be programmed. Unfortunately, we don't know which ones they are. But for NPH patients, they're absolutely godsend. They help prevent the subdural hematomas. And I hope and we'll find a better way to make these less expensive so that we can have more use of these things. The new shunt by the Johnson Johnson, now the Integra system, has a virtual off, which is very, very important. It's at about 400 millimeters of mercury. So if you're trying to wean somebody from a shunt or even get rid of a subdural hematoma, use of this valve with the Certus programmable valve having a very high virtual off can help us maybe wean the shunts in the future. The antibiotic shunts, nice studies. There are some improvements. I would like to show our colleagues who are not familiar with Maurice Chou's work from France. Beautiful work, and he came out, we were shocked. He had 600 patients with very, very low infection rate, and then another series with zero infection rate. And Maurice was flamboyant, but he had certain rules. That is the first case in the operating room, which is hardly ever given to a shunt. It's always the tumor or vascular cases that get it. So things like that, to avoid complications and paying particular attention, can help us reduce shunt infection rate, please. The antibiotic impregnation with rifampin, it's actually supposed to be rifampin, sorry, the rifampin and clindamycin and et cetera are very well. And I'll speak a few words about the BASICS trial. The results just came out last year, a very nice study done in England with several thousand patients in each arm with no shunt antibiotic impregnation, the standard the rifampin and the clindamycin, the bactericidal shunt or the ARA shunt, if you will, or a silver impregnated, there was a 6% to a 3%, a 50% decrease in shunt infections, if you would. But interestingly, the silver impregnated ones didn't do as well. However, I would like to also quote my dear friend Ben Worf, and I worked in the same hospital that he mentioned for a few weeks, I'm sorry, in Uganda. His last paper did mention that in Uganda, where infection rate was very high, he did not find it to be a statistically improvement using antibiotic shunts. So it is a good idea if you have a very high infection rate, meaning 10, 12, 15%, you can bring it down to 5% or so. But if you have a 5% or 8% shunt infection rate, you may not see the benefit. The idea of a smart shunt is around the corner. We always dream of a shunt, and these are multiple requests, the basic need that we want for the shunt companies to, most importantly, make it cost effective, of course, which is impossible. But we have technology already, friends. We have technology, it's called a lab on a chip. We can send man to the moon. We can do all these technologies. I went to NASA and worked with them because I live in Florida and NASA's down the street. Yet we're not able to find the resources to find the various things we need. A shunt that will monitor pressure and tell us about flow. It'll tell us about obstruction, self-adjusting maybe, waveforms. These are all things we would love to have in a shunt that doesn't give us more hardware to deal with, but hopefully it'll work. It's a dream of the future. And the Hydrocephalus Association gave $250,000 to develop this. Sansia's smart shunt device is still being developed. Endoscopy has been around since over a decade, over 100 years, over a century. And since now used multiple techniques. Les Binet first used the pediatric urology cystoscope, which is interestingly, that's the one I was trained in by my mentor, Jack Walker, back in the 80s. That's the first scope we used to do a third ventriculostomy. With a flexible or a rigid endoscope, there are trade-offs, but you need to have a nice steep learning curve. The flexible endoscope gives you the advantage of doing seeing around corners and maybe doing choroid plexus coagulation and even other septations. And it seems to be much more easable, but it does take some getting used to and training. And the optics are naturally much better with the straight lens scope as opposed to the flexible. With the endoscope, there's still questions. We don't know what's the best use for them. Should we add a CPC, choroid plexus coagulation? Should we find a better way of doing it? And how long do you follow a patient after ETV? How successful is an ETV? How big does a third ventriculostomy opening have to be? Most people feel it must be at least 5 to 6 millimeters, and there should not be any arachnoid adhesions for it to be successful. The word is still out if endoscopic third ventriculostomy is beneficial in NPH. The Italian study and subsequently other studies are still equivocal. I'm not sure why it would work, but it has been tried and there's some proof for it. As always, what is the best age in a baby for endoscopic third ventriculostomy? I'm sitting before you. I have done them in babies less than 2 months old in Uganda. Successful. I was very pleased. And you can do them. The anatomy is different, but you can do successful ETVs and choroid plexus coagulations in babies, 4 to 6 kilograms in size and 2-3 months of age. Many still unanswered questions about hydrocephalus. What is the function of CSF? Why do we have CSF? I'll touch on that later if we have time. Friends, I would like for you to think of one thing, please. 15% of our cardiac output goes to the brain. Almost a liter a minute goes to the brain. Most all of it comes back, except for a very small amount. 0.33 mil per minute is left up to be made as CSF, which is about 500 mil per day. If we think that the child or an adult is having trouble absorbing 1/3 of their spinal fluid, meaning 0.1 mil, that's 30%, the patient may be in trouble. The only thing we can offer them is a shunt. Is there a way we can teach somebody to absorb 0.1, 0.2 mil of CSF per minute? I'm sure it's not that much. If you think of a syringe, it's a small amount of fluid. We have not yet spent enough resources in teaching the brain to absorb its own fluid. We can find better ways to reduce infection risks. We have so many protocols, we have so many methods. Why is it 30% in some places and 6% or zero for shunt infections? We can find a better way. If we saw beautiful pictures of aneurysm clippings, everybody around the world does the aneurysm clipping essentially the same way. Taking out a tumor, we do it the same way. We don't seem to have the answers for hydrocephalus for some reason. And can the shunt be maintained long-term? Can one shunt last 10, 15 years as opposed to so many? And yes, there are patients who've had 100+ shunt operations by the time they're 10 or 12 years old. I've seen them, I've taken care of them, and it's called a century club of such patients, young children who've had hundreds of shunt operations. We developed this technique a long time ago called a percutaneous endoscopic recanalization of the catheter. You can see this endoscope here. It's 0.5 to 0.8 millimeters in diameter. It goes into the shunt actually, and you can see an obstruction in the shunt proximal. This is a live patients. I didn't insert the videos, but you use a small Bugby wire to go with it. And once you coagulate it, the lumen are open and the CSF is flowing. Here you can see the CSF coming out after we coagulate. It's a modified shunt tap. It takes 10, 15 minutes or maybe 8 minutes. It can be done outpatient, and it's actually wonderful. But the question is, how long will this stay open? And to our studies, it has stayed open as long as there's regular shunt open shunt provision. Some other questions left in pediatric hydrocephalus. What type of a shunt? Should we use a programmable shunt or non-programmable? Antibiotic impregnated, is it necessary? Is it worth it? Many studies say it's worth it for the cost in the long term if you can afford it. Shunting is a multi-billion-dollar industry in America. Of course, in India and other places where the infection rate is high, we can reduce it by doing this. In pediatric, the common question is it benign ventricular enlargement without any symptoms, or is it true hydrocephalus that need to be operated? Every week we see such patients, the dilemma of yes or no. There's so many factors, but in the interest of time, I'll mention to you, it's just that all the typical signs of continued follow-up, because committing a baby to a shunt is, of course, high risk. Use of shunt protocols, there are enough research data to show if we all did something the same way, then it'll come out to be better. Unified shunt protocols developed by the Pediatric Research Network out of Seattle has been very beneficial, very beneficial. For NPH, we have tremendous improvements in MRI technology, and they're able to give us better definitions of who needs a shunt and who doesn't. Protocols for how to develop a shunt, how to develop a methodology for identifying a candidate is important. We do it by team meetings in a committee, and the group decides, including psychologists, therapists, neurologists, developmentalists, everybody decides which patient has the proper need. In this bottom left picture, you see the callosal angle. If it's more than 40 degrees, you worry. If there, of course, transependymal flow, there are other flow findings in the aqueduct. These are all extremely important to separate it out from DESH, D-E-S-H, the fluid over the brain. These are all conditions. If we can identify the right patient before the mental changes, NPH patients often respond very, very well. Many protocols and the neuroradiologists have now identified a very, very nice set of parameters separating atrophy and dementia like Alzheimer's versus a hopefully treatable patient with NPH. Having said that, we're still only finding 5 to 10% of patients with Alzheimer's that should and could improve with shunting. A couple of words about brain turgor. This is a interesting concept is B sub T. The brain is like a sponge. It can be soft, it can be hard. And in patients who have, for example, benign intracranial hypertension or pseudotumor cerebri, their brain is very stiff. The pressure inside can go tremendously high. The ventricles may not get larger. And if we think about all the changes within the actual fibrils that hold the neurons and everything together, it's a matrix that can be stiff. And if it becomes stiff, then you have conditions such as a split ventricle syndrome, which we may cause by shunting somebody and draining too much fluid. We need to understand this in relation to the vascular changes and the pulsatility, which I'll talk to you in a minute if we have time. This is the same slide I showed you a minute ago. I'm trying to move fast in the interest of time so we can get to the presidential address. The main consideration is, can we find a better way to see at the cellular effect the problem? Friends, the problem we have is that the basic understanding is that the CSF is made in the choroid plexus, and the green fluid, as you see circulating from the choroid plexus, it goes to the arachnoid villi, should be absorbed at that level. Why do we have CSF? What does it do? Is it a byproduct of life? Is it a transport mechanism? We have CSF doing all the work before the vessels are even developed in the brain. Is it help you with shock absorbers? Is it a messenger system? These are all unanswered questions we should know about. If you think of arachnoid villi, because we had them from Dandy and the Black Fan a century ago, friends, we do not have arachnoid villi in babies and children. That I've thousands and thousands of operations, but my babies and children don't have arachnoid villi. They don't have those descriptive surfaces where CSF should be absorbed. At the most, they have some temporal pits. That's it. So the CSF is probably being absorbed in many other places, including the choroid plexus. Part of our limitation is simple. We don't have animal models to tell us how to do this better, that we can extrapolate to the humans. Here I just circled the Hydrocephalus Texas rat up here, and the several mouse models, especially mouse, which we know has hydrocephalus due to the hidden gene problems. These two animals we've used in our labs as well, and especially the HTX rats. I'll show you some. Most recently, last year, we had a new model that came out with a specific genetic abnormalities, but unfortunately, this is not yet tested as well. And this is the HTX model. By the time the animal's 10 days old, you can see the hydrocephalus and the animal's already affected. You can see that day 4, there's a sign, you can pick up an early sign compared to the normal one. And yes, this is a 4-day-old pup that I put a shunt in. You can keep them alive for a year with a shunt. Here's the ventricular right there, and abdominal portion, and it's a PE10 tube, but they can work, they live. Just so I'm an expert in rat shunting. It doesn't mean anything. I've made the same mistakes on rats I have with taking care of humans. Fred Epstein, bless his heart, a world-renowned pediatric neurosurgeon, said, look, it's a dream. Tim George, the predecessor to mine, pediatric neurosurgery editor-in-chief, same problem, how can we do this? And most recently, we lost Jim Goodrich last year due to COVID, or this year, excuse me, due to COVID. And he said the same thing. What is the change? Nothing in 1,500 years. To my benefit, to my good luck, Dr. John Holter, the man who invented the shunt, as you see him here with his son Casey, who had the first shunt inserted back in the 50s, came to my lab, started my efforts, encouraged me tremendously, and told me one thing simple. All hydrocephalus research stopped with the shunt.
They're ready to start a presidential oration, sir.
I'm ready to stop. Thank you so much. I'm sorry that they took up my time with somebody else, but you all have a wonderful day. Thank you so much for the opportunity.
Thank you, sir.
Thank you.